Hello, everyone. Welcome to another episode of the Tokyo Living Podcast Injury Edition. This will be the last injury edition of the year. It'll be the second last podcast of the year. We have a great show next week with a real estate agent, Emil Gorgies. So if you're tuned in to our regular show, look out for that one. That'll be dropping as the last episode of 2023. But in terms of our injury editions, this will be the last one. So thank you for those that have tuned in thus far. I hope that we've been able to provide some useful and interesting content for you. And we've got a number of different topics lined up to speak about next year. Today, I am going to attempt to tackle the topic of lower back pain. The episodes that we've done so far have been focusing on more specific conditions. I've been hesitant to talk about something like back pain because it is such a massive topic. It encompasses a number of different conditions. And is by far the most complicated area of the body that we treat. But because it is such a common area for people to experience pain in, and because there are a lot of different approaches to both the assessment and the treatment of lower back pain, I thought that it would be useful for me to share my current thoughts on the topic. Talk about how I go about assessing and treating individuals who are experiencing lower back pain. Talk about my understanding and my interpretation of the current research findings that we have, and just try and give people a little bit of information and perhaps touch on a few different points that people aren't aware of, and hopefully in the process. Try to help people that are listening who may have experienced back pain, or may currently be experiencing back pain. This is my second last working day of 2023, and I've set aside quite a long time to speak about this topic. I don't know how long it's going to go on, and I have no doubt that I'll probably come back and do a part two, because as I'm rambling on, I'll probably forget a lot of important points that I need to touch on. I have a notepad full of notes that I'll try and sort of work through, but I really don't know where this is going to go or how long it's going to go for. So if you're traveling over the holidays, you might want to bookmark this one and save it for a long drive or a long flight where you want to sort of relax and listen to what's going to be probably a fairly long chat about this topic. Now, throughout the show, we're going to talk about what back pain actually is, what people are going through when they're experiencing pain in this area. We'll be talking about different back pain conditions where the diagnosis of conditions is important and when it's not so important, and why a lot of the time it's not actually important. As I said, we'll talk about the way that I go about assessment and treatment. We'll talk a lot about pain because I think understanding concepts around pain is important for a lot of different conditions, but back pain in particular, I think, is an area where an understanding of pain is crucial to effective management of these conditions. We'll talk about some common myths and misunderstandings around back pain. We'll talk a bit about posture, about core stability, about lifting, a bit about ergonomics. We'll talk about the safety of certain exercises. And we'll also talk a little bit about how we can go about decreasing the likelihood of experiencing lower back pain. Now, I'm not going to use the word prevention because we can't prevent lower back pain, and I don't think that we necessarily should be aiming to do that. But we'll talk about how we can potentially decrease the likelihood or decrease frequency of lower back pain episodes, and also how we can decrease the likelihood of the lower back pain becoming recurrent and also persistent or chronic. As we'll talk about in a little bit, there's a big difference between acute lower back pain and persistent lower back pain. And we think of them as two very different conditions, but one can lead to the other and often does. And we need to talk about how we can potentially change that. And then we'll also talk a little bit about management when we can't actually resolve back pain, because this, this is a truth amongst the back pain world. Is not everyone will recover, and not everyone will be pain free. But that doesn't mean that we can't increase someone's ability to lead a fulfilling life, even in the presence of pain. So if that all sounds like something you'd like to listen to or watch for a little while, then stay on board and let's get stuck into it. So why is this an important thing for us to talk about? I think at this point we will sort of break out and talk a little bit about statistics.
Hey everybody, here's some fun facts.
Because I think this, in back pain, it is important to sort of understand the burden and the financial burden and the toll on society and on people's life that this actually has. We know that about 85% of people will suffer an episode of lower back pain in their lives. We know that about 50 to 80% of those will have a recurrent episode, and 20 to 30% of those will actually develop an ongoing back pain problem. And so it then starts to become persistent or chronic. In 2016, lower back pain was a $134 billion problem in the United States alone. Back pain accounts for about 25% of workers' compensation claims. It is the most expensive healthcare problem in people between 20 and 50 years of age, and is the most common cause of disability in people under 45 years of age. It's the highest in terms of years lived with disability, and is the most disabling condition, and that has been shown in 1990, in 2006, and again in 2016. And I think that just understanding how long low back pain has been such a big burden on society is important to consider when we talk about the different assessment and treatment methodologies that exist. Throughout this episode, I will express my opinions based on my understanding of the research and on my 20 years experience dealing in this space. I will quite comfortably sit on the fence in a lot of areas, because there are things that we just simply don't know about low back pain. And I think that if anyone claims to know, exactly why people experience back pain and how we go about managing it, I think they're truly delusional, because obviously, as an industry, the healthcare industry, we're not doing a great job overall, and you can see that from the statistics that this, 20 years on, is still the biggest problem that we're dealing with. So that's all sort of the statistics side. So myself as a healthcare professional, I obviously need to take that into account and try to do my best to contribute to lessening the burden of lower back pain on society. I guess more relevant to me as a healthcare professional is that, just based on these statistics alone, statistically, I'm going to see more people, especially in a private practice like ours, where we're serving a large, diverse population. We're not specialists here. We're seeing all areas of the body, but statistically, we're going to see more backs than anything else. So if my job is to help as many people as possible who are suffering some type of musculoskeletal pain, then it's obviously very relevant for me to have a good understanding of everything around this condition. And also for me personally, I really enjoy working with people that are experiencing back pain, because there are so many different contributing factors and different treatment options. It does give us as clinicians a lot of tools to manage people experiencing pain. And it also provides us with different streams in which we can do our detective work, because essentially as a physiotherapist, that's a lot of what we're doing. We're trying to do detective work to try and figure out exactly why the person is experiencing pain, and how we can go about trying to help them. And so for me, it's a very satisfying area to work in. So what are we actually talking about when we're talking about lower back pain? Well, if someone is experiencing pain in the area of the lower back, what does that actually mean? Now, I think this is a good time to start talking about some of the concepts in and around pain. The most widely accepted definition of pain comes from the IASP, the International Association for the Study of Pain, and they defined pain, and this is an updated definition from a couple of years ago, as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So what does that mean? An unpleasant sensory and emotional experience. I think that anyone who's experienced pain, they will identify it as being unpleasant. It's an emotional experience. It's something that we, as a person, experience, and only we can know how it feels to experience that pain. So it's a very personal thing. It's resembling that associated with actual or potential tissue damage. So when we experience pain, often we have the experience of something happening to the tissues in our body. Okay. Now, whether or not something is actually occurring to those tissues is a discussion we'll get into in a little bit. But that's essentially what we're feeling. So we experience this sensation, and the sensation creates the notion that something negative is happening to the tissues in our body. Now, that's just one definition. Now, there are other definitions of pain, and there are other interpretations of what it means to be in pain. And this definition that is proposed by the IASP is really just talking about like physical pain, because we can feel emotional pain, and sometimes this is the unpleasantness that we feel with emotional pain can be much worse than physical pain. You know, the death of a loved one, for example, is extremely painful, but we don't have that same experience that mimics a negative occurrence to something in our body, in the tissues. And if we then sort of expand this out and talk about back pain, so now we're talking about an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage to the area of the lower back. Okay, so we're having this negative experience, and it feels that this negative experience is occurring in our lower back. Okay, now, sometimes we will have leg pain associated with lower back pain. Sometimes it is associated with numbness and weakness and neurological symptoms. Sometimes it's not. And sometimes, often when it's not, we will class this as a referred pain from the back. And we'll talk about that in a minute, what that actually means. I would group this in the same sort of condition as some lower back conditions, but for the time being, we're talking about back pain as an experience. So for this working definition, the back pain experience is when an individual is having this negative experience and they perceive it as coming from the lower back. Okay. Now, the actual perceived tissue damage is the interesting one. So there doesn't need to be actual tissue damage to cause pain. And I think this is probably the biggest conceptual shift that people have when they start to learn about pain, because I think intuitively we understand that if we have pain in an area, there must be something wrong in that area. Now, with all the injury podcast episodes I've done so far, I have requested that people watch or listen to the episode regarding load, because load basically and understanding all the different types of load that contribute to an injury is really important in diagnosing and treating injuries, because any of those different types of load has the ability to produce, or at the very least contribute strongly to a pain experience. So all of the different types of load can contribute to pain, and the pain experience can be modulated by a number of different things. So essentially, when we have pain, It is a sign that the brain and the central nervous system is under some degree of threat that it believes requires protection. So that's the job of the nervous system. It is to protect. We can have protection occur through pain. So if we're experiencing some sort of threat and the brain perceives that that threat is substantial enough to require protection, then we'll have pain. We may have pain. We may have other responses. So another protective response might be increasing muscle tone in a certain area. So let's say the body's trying to protect us. It might tighten up the muscles around the back and not allow us to move. And by doing so, that in turn then starts to contribute to pain. And there's a lot of different things that can, turn up the dial or turn down the dial on that protection, that amount of protection that we're given. So when we have danger that is relayed back to the brain and the central nervous system from the tissues, it's done so via a process that we refer to as nociception. Okay. So nociception is essentially the ability of the body of different specialized parts of the nervous system to relay what we call noxious stimuli back to the brain. Now, I do want to try and limit the amount of technical language that I use throughout this episode, but there are going to be a few technical terms that are key, and nociception is one of them. So understanding that these nociceptors, they pick up danger signals, and they are usually accompanied by other types of nerve fibers that are relaying information about the type of stimulus that we're experiencing. So all the nociceptive system can do is tell the brain that there's threat there. We don't know whether that threat is from a burn, from an infection, from trauma, from inflammation. We just know that there's danger. We have these secondary nerve fibers that then accompany that nociceptive system to give the brain a little bit more of an idea about what's going on. Now, interestingly, from an evolutionary perspective, this nociceptive apparatus actually predates the development of a brain in living organisms. So the ability of an organism to be able to detect threat actually, was there in place before we started to develop a brain that had the ability to act upon that threat and to consciously modify exposure to the threat. And I think that is a really important point to consider because we have this threat detection system, but what we're using to manage the threat that's coming into the system in terms of our brain sort of came along at a later stage and had to adapt to fit in with that system. And so that's potentially one of the things that contributes to a slight dysfunction in between our nociceptive system and our brains that are acting upon this nociception. So when we have nociception, it triggers or sends signals to the brain, and the brain has to decide how much of a threat that is, and then put out an appropriate amount of protection in terms of pain. Now that can be modified by a number of different things. So our beliefs around pain can modify the amount of pain that we're getting. So if we have an amount of stimulus from our nociceptive system, but we believe that there is something inherently wrong with that area where we're feeling the signal coming from. So let's say we feel that we have an unstable knee. Or let's just stick with the back. Let's say that we believe that our back is unstable because we're not strong enough, we don't have enough stability, or we have been told that there is a tissue problem there that is likely to cause future pain. Then that belief then influences the amount of pain that we're experiencing as a result. So we have these signals come up, and then we have this belief that amplifies the signals, and so the painful response is going to be greater. If we have experienced pain in the past, that will increase the amount of output, and especially if our experience had been very bad. So if we've had a back injury in the past and we had to maybe miss work, or we know that it was extremely painful or it affected our lives in a very negative way, then that's going to influence the amount of pain that we're getting as well. And that's important to take into account. The psychological state of the individual experiencing pain can have a massive impact as well. So if we are under a large degree of stress, then sort of like the computer that I'm recording this show on at the moment, if I'm doing too much on the computer, it starts to get overloaded and it starts to not function quite as well as it should. And our brains are the same. So if we've got a lot on our mind, we're trying to deal with a lot of different things, then the brain's ability to have precision with the amount of the output of pain is reduced. So we're having a certain amount of input and we can't quite gauge how much protection to provide. And so the default is just to provide more. So again, that is another way in which the pain response can be upregulated. And then by the same token, stress can also affect the periphery. So when we're stressed, we have changes in our immune system, changes in our endocrine system. So we have different hormones. We have increased levels of cortisol, and the nervous system is very sensitive to all of that. So when we're stressed, we are in a more stressful environment, and those signals are more easily able to, in many cases, be passed up to the brain, and so the brain is quicker to act. So there's a lot of different ways in which psychological stress can contribute to pain, and it's not just a lot of people note that I hold my stress in my shoulders when I'm very stressed. I tend to get tense, and that can be very true. And so we can have a specific biomechanical effect of psychological stress, but there's also a number of different other systems that can be influenced as well. And then we've talked about how the hormone changes associated with stress can influence the sensitivity of the nociceptive system, and a lot of other things can influence that as well. And when we have inflammation, for example, that causes nociceptors to be more sensitive. If nociceptors are activated time and time again, each time they're activated, they get more easily activated. So by this process, the body, the longer that we deal with pain, the easier it becomes to create pain. So the body gets better at producing pain. And that's why chronic or persistent pain can become such a problem. We know that the environment in which an initial injury occurs can also influence future injury. So, for example, if you happen to injure yourself after eating a particularly spicy meal, where that spiciness of the meal might have caused a change in the metabolic state of your system, then it's not unusual for people to experience more pain when they eat those same foods, because that sort of metabolic state of the system is reproduced because of the foods they eat, and therefore the nerves are more likely to get sensitized. The common one we see is when people are experiencing their menstrual cycle, and there's obviously hormonal changes that go along with that. There might be biomechanical changes that occur as well, but it's often the case that the nerves are sensitive to that specific hormonal environment that happens at certain phases during the menstrual cycle, and so people are more likely to experience pain at that time. So a lot of the time, there is nociception involved in lower back pain. Some may argue that there needs to be some nociception there to initiate a pain experience of any kind, including low back pain. But I guess at the moment, the current view is that nociception isn't necessary for pain, and it's not sufficient for pain. Now, we know that nociception is definitely not sufficient for pain. So we can have nociception, we can have the threat experienced in a certain area of the body, but not experience pain. for example, and this is the I guess the most dramatic example. Let's say we fell from a high height, we fell on our back, and we caused a fracture of the bone in our back, of a bone in our back, a bone in our back. Now, that was likely to be very painful. So the body is going to detect via the nociceptive system that there's been a large degree of trauma to the tissue, being the bone. And then we have other sensors around that area that sense the inflammation that occurs after that, damage to other tissues around that bone. And so the brain is getting a picture of what's happening. And the fact that there's been such a large trauma and damage to the tissue, the brain concludes that at that time, a lot of protection is required. So it's going to send a considerable amount of pain to essentially stop us from causing further damage. But let's say we fell from a high height, but we were doing so because we were trying to save a child from a burning building. Then the threat associated with not being able to save that child is likely greater than the threat associated with the damage to the back. And so in that environment, you may not experience pain, or you can certainly experience pain to a lesser degree, because the brain has concluded that right in that moment, its priority is not to protect you from the injury to your back. It's to protect the child in the burning building. Now, that's a very extreme example, but it is a good example just to start getting our head around that concept, that there's not a direct correlation with the amount of tissue damage and the amount of pain that we experience. Now, in terms of being the opposite, that nociception is not required for pain, that's a little more complicated. Again, the most extreme example is what we call phantom limb pain, which happens to amputees, where they experience pain in a limb that no longer exists. Now, the argument here is that there's likely been stress to the nerves that were in place prior to that amputation having occurred. Because people don't experience phantom limb pain if they were congenitally born without a limb. It's when that limb was present before and is no longer attached to the human skeleton, that people will experience pain, but it's pain associated with memories of an activated nociception within that area. But still, I think it's a good example in that, the nerve fibers aren't, at the time when we're experiencing pain, they aren't actually being exposed to a threatening stimulus. But as I said, for the large majority of injuries, I do believe there is, at least in the beginning, a degree of nociception, stress on the tissue that is causing at least the initial pain. However, the longer we experience pain, as I said, the nervous system gets better and better at producing pain to the point where there may not be nociception required for a painful experience to be present. And so we've talked a little bit about the different contributing factors that can cause someone to experience pain in the back. And this is sort of what we refer to as a biopsychosocial model of pain. So bio is the biology, the psycho is the psychological aspects of pain, and the social is the social aspects of pain. So, for example, if we have a friend or family member that's experienced pain, then that may change our experiences with pain. So if we have, for example, a family member who has had back surgery in the past, then and we know that they've gone through a lot of pain and trauma and psychological stress with that surgery experience, then that's going to influence how we perceive messages coming from our lower back. They're going to be perceived as being more threatening because we have been directly exposed to someone who has had a negative experience associated with back pain. But we also, the social aspect also influences the management of pain, because people with a strong social network are generally better equipped to deal with pain and make a better recovery. sometimes the waters get slightly muddied in terms of biopsycho, because even when we're talking about the psychology associated with pain, it's still related to the biology, as we talked about before. We experience this nociception, and the brain is in control of what we're experiencing in terms of our pain. However, that is, the brain is still a biological structure. So where I'm sort of going with this, in recent years, there has been a push to recognize more of the other contributing factors to pain. And so this is an umbrella movement, is sort of been described in terms of pain science or pain education. To the point where there has been there's courses, and I've undertaken these courses that are purely around explaining pain and discussing pain concepts with people who are experiencing pain. And in a lot of ways, this has been a fantastic initiative, because we know that when someone has a better understanding of pain, it can help in terms of decreasing pain. So if we understand that our pain isn't necessarily associated with tissue damage, then the messages that we're getting from the periphery, the nociception that is being interpreted, can become less threatening. So just having an understanding can decrease pain when it's combined with other modalities. Also, when we have an understanding of pain, it increases the likelihood of us engaging with other interventions that we know are helpful in terms of pain. And one of the big ones is exercise and activity modification. Because if we think that, for example, there's something damaged in our back and that's causing our pain, then it's probably going to decrease the likelihood of us engaging in physical activity for a fear of making that damage worse. However, like I said before, pain education needs to be combined with other active modalities. In a relatively recent study, they found that pain education alone wasn't sufficient to decrease someone's pain. And so what has happened, as is often the case with things in our field, is a pendulum will go too far. So with a lot of things, we see a change in people's approach to certain aspects of health, but it's sort of taken too far, and to the point where it doesn't become as beneficial to the individuals that we were trying to help as we would like it to be. And I think the pain science, pain education movement is being, unfortunately taken too far in the wrong direction. So some clinicians have relied, and I've been guilty of this myself earlier on in my career, and been guilty of making pain education the main focus of someone's treatment plan. And whilst it may be an important part of the treatment plan, it needs to flow into other more active areas of pain management. The other thing that is problematic is that there almost seems to be a dichotomy with how we treat certain conditions. So I've heard clinicians talk about, I'm going to manage this person but with strengthening, or with manual therapy, and whereas this person I'm going to treat with pain science, which isn't it's not really a scientific way to approach pain management to start with. But there shouldn't be a dichotomy. There's obviously more of what we call a central component, more of a maybe a psychological or social component to people's pain, and then in others there may be less of that. But we always want to be considering the different elements of pain, including the psychological and social elements of pain, in every presentation of pain that we're treating. The other problem is when the messages that we're trying to get across in terms of pain education are misinterpreted, and often that may be the fault of the health practitioner. There have been many people who have come away from consultations with well-meaning health practitioners with the idea that they're being told that the pain is all in their head. And I think this is a really disappointing outcome. And I'm sure that there's been people that have consulted with me that have come away from the consultation with those same sort of messages, that I'm not only implying that the pain is in their head, but also not really validating the symptoms that they're experiencing. And obviously, like every health practitioner should be doing, I'm always trying to improve myself and improve my ability to explain pain to people and to get those messages across in an accurate but supportive way, and in a way that is empathetic, that makes that person understand that I believe in what they're experiencing. I understand the pain that they're experiencing, but also give them some tools through pain education that are likely to lead to a more optimal outcome. But essentially, when we argue that pain is in the brain, the brain is the boss in terms of what we're experiencing in pain. As we've sort of established, even if we have a severe injury to a certain part of our body, that alone isn't enough to cause pain. There needs to be contribution from the entire nervous system to produce that painful experience. Okay, so as always, I've rambled on too long there, but I hope that has been somewhat interesting and helpful for you, getting an understanding around pain. So we're going to now talk about acute lower back pain. So now I hope that acute isn't too much of a technical term. However, I do feel that sometimes it is misused by individuals experiencing pain. So I have heard that people say, I have this pain and it's very acute. And I think that sometimes people use the term acute to describe the severity of a painful symptom. However, the term acute is used to describe a painful experience that comes on at a specific time. So the typical acute injury, I went down to pick up my child and I felt a pain in my back. I felt my back go. So when we experience an acute injury, and especially if it's the first time that we've experienced this acute injury, it may be associated with tissue damage. There will often be an initial stress to a certain tissue, which will then be followed by a protective, I guess, two different protective responses from the brain. Now, we've talked about both of these so far, but we get the protective response from pain. So we have the message come from the area that's been strained. The brain identifies that as a threatening stimulus. It will send pain to protect us from further damage, but it will also do other things like tighten up muscles to, again, protect us from further damage. So we get this muscle spasm. And the muscle spasm itself can be a secondary noxious stimuli. So now we've got at least two types of noxious stimuli going back to the brain. And so that's where we start to get this compound pain, because pain will then drive more pain. So that's one of the reasons why you might have a certain strain, like you feel something, that didn't feel good, but I kept going through my exercise, or I kept doing whatever I was doing. And then over the course of the next few hours, and then maybe particularly the next day, it gets a lot more painful. So part of that is an inflammatory response. So when we injure a tissue, we generally get inflammation. And some of the nerve fibers that are sending messages back to the brain regarding either nociception or the type of negative stimuli that we're experiencing, they're slow acting. So they're actually taking their time to get back to the brain. We also have the inflammatory process itself isn't an immediate process. So that's something that builds over time as well. And then we get this compounding of the muscle guarding as a secondary protective response from the brain. And then that creates more nociception. So we get more messages going out to the brain, more protection, and then we start to build. And so, a typical sort of nasty strain in the back will get a bit of a strain, bit of pain at the time. And then that might build to the point where the next day we might have a lot of trouble getting out of bed. So when we experience this type of presentation, what might be going on in the back? We have a lot of different structures in the back. We have our intervertebral discs. So the intervertebral discs basically sit between the vertebrae, hence the term intervertebral, and they basically allow for some of our movement to occur, and they also help buffer the compression that happens during of our spine through day-to-day movement. We can get a strain of the disc as just as we would strain or sprain other parts of the body. So, when we get too much pressure being put on the disc, we get a slight tear, and that invokes an inflammatory response. And that can be a potential source of nociception. We can have the joints in the lower back that can be affected. So the most common of these are the zygapophyseal joints. Please don't remember that. If you want to remember them, you can call them facet joints. It's what we generally refer to them as. Now, this may be more associated with rotation or a backward bending type strained motion. We can get a muscle strain. There's a lot of muscles in the back, and they're all susceptible, like any muscle is, to excessive loading. And then we can also get the bones themselves. So if we have an acute injury that is traumatic enough to cause stress and fracture of a bone, then that will be a potentially strong cause of nociception. Just like any tissue, all those tissues have the ability to heal. Now, a muscle might heal quicker than a disc, which may heal quicker than a bone, but they all have the capacity to heal. Part of the problem has been a bit of the stigma associated with the intervertebral disc, and especially terms like a slipped disc, which I'm hearing less these days, but I still hear it a bit, and I heard it last night many times from an individual who unfortunately was been suffering lower back pain for quite some time. And she had been told by a health professional that she had a slipped disc. Now, I should go back and say that's what she understood as what the health practitioner was had told her. I wasn't there when she was given this initial information. So as another health professional, I need to be careful in terms of what I'm interpreting coming from that individual. Might not necessarily be what she has been told, but it's basically her interpretation. Discs can't slip. They can't move out of place. Now, they can herniate, they can bulge, they can protrude. Our disc is made up of essentially two different parts. We have the outside part, which we call the annulus fibrosus. And so annular, it's circular; fibrosus, it's fibrous tissue. And then we had the nucleus pulposus, so the nucleus more the center of that disc. And over time, when we expose certain parts of the disc, now usually the back of the disc may be in combination with one sort of side of the disc, depending if we're doing a lot of rotational movement in one direction over, this usually happens over years, we can get the nucleus start to move out towards the back of the annulus. And start to bulge. So, if we imagine that the disc is lined up between the two vertebrae, and in the textbook, that's the boundaries of the disc, those boundaries might start to widen. Right? And then we get to the point where if there enough tearing has occurred in the back of the disc, then the nucleus can start to herniate through. Now, part of the problem is that sounds quite graphic, and it doesn't sound nice, right? But the fact of the matter is, it's a normal part of our aging process, and a disc herniation, and even a disc protrusion, where the disc starts to come all sort of the way out, and the margins of the part that's protruded is actually wider than the margins of the part of the disc where it's protruding from. And those of you who are watching the video version of this, I've attached a picture to explain this. But even in the case of a disc protrusion, that alone isn't enough to cause pain. It's not even enough to cause nociception. Because it's an aging process, because it's just a change that happens over time, it's not enough to even signal to our brain that something is wrong. Now, groundbreaking study, I think from 2015 by Bryn Jekyll, I'm sure I'm pronouncing that incorrectly, but they showed that the incidence of disc pathology, so changes to the disc structure, are extremely common even in asymptomatic individuals. So the general rule is if you take your age and add 10 years, so for me, I'm 41, if I add 10 years, 51% of 41-year-olds will have some evidence of disc pathology on an MRI, even if they don't have pain. I shouldn't say even if they don't have pain. 51% of 41-year-olds who have never had pain will have disc bulges, disc herniations, disc degeneration, changes to the disc, but don't have pain. Now, maybe they have nociception, but that nociception isn't enough to trigger a painful response. But from my understanding, there's a lot of people that change in the disc structure alone isn't enough to produce that nociception. Now, it may make that person more susceptible to a strain occurring in that part of the disc, but the structure alone isn't enough to produce pain. So someone has experienced this acute onset of pain. How do we manage this? So I've talked a bit about some of the potential sources of nociception that can be there when we have lower back pain. Is it important for us to identify the source of pain? Not really. I'll go on to talk about how I assess lower back pain in a minute. But in terms of diagnosing the structure that is leading to the nociception, for most acute episodes of lower back pain is not necessary. Right? Most lower back pain will settle within a time frame of around 6 weeks. Some may settle in a couple of days. Some may take 3 months to get better, but usually it does get better. Okay. What do we do when someone's experiencing this lower back pain? Well, it depends on what we find in our assessment, which again, I'll go into in a second. But mainly our focus should be on doing what we can to settle that lower back pain. Sometimes there's nothing we can do. So as a younger practitioner, if someone walked in with acute lower back pain, there would be an immense degree of pressure to try and fix that person and get them out of pain. Sometimes it's possible, sometimes it's not. Sometimes the nervous system is wound up to a degree where that just isn't possible, and sometimes there is a significant amount of structural damage and inflammation that just needs time to settle down. What we can do, though, is provide that person with education and try to reassure that person that the acute lower back pain experience is something that's completely normal, that isn't necessarily associated, and is usually not associated with serious structural damage. That a lot of their symptoms may be coming from the muscle spasm that they're experiencing. And reassurance that most of the time this does get better. The education part is important because the fear and the worry that happens when we experience lower back pain can start to edge this condition in the direction of persistency and chronicity. If we start to develop very negative beliefs around what's going on in our body, as we discussed earlier, this alone is enough to trigger a painful experience. And so it's really important when someone experiences lower back pain to get those messages across as soon as possible, to give that person the best opportunity to recover from this painful experience without it becoming chronic. And then from there, like every injury, once we allow enough time or use our modalities to get that painful experience to settle, not necessarily completely pain-free, but settle to the point where we can initiate some type of activity, then we build that person back up to their previous level of activity. And it doesn't need to be pain-free, because often once we start to get back into activity and the person can perform a certain activity without any increase in their pain, then as we concurrently increase their activity, pain levels tend to go down at the same time. And so in terms of diagnosis, like I said before, often changes, and not only changes with the disc, but changes to a lot of different structures, and not only in the lower back, but all over our body, as we'll talk about next month with when we discuss rotator cuff related shoulder pain. We can have a lot of changes that are not associated with pain. So the diagnosis can actually become problematic. If someone has an acute episode of lower back pain, and then they go and get an MRI, which shows a disc bulge or disc herniation, that can be really damaging, because now they've got this picture of something that is supposedly very wrong in their bodies, and that can influence their beliefs. And as we know, the negative beliefs can then start to increase the amount of pain, upregulate that protective mechanism that someone is experiencing. And this is one of the reasons why we don't like imaging for the majority of lower back pain cases. We'll go on to talk in a minute about when we do use imaging, but for the majority of the cases, we don't want to image someone early on. We know that when we image early on in a case of a lower back pain experience, that person is more likely to experience chronic pain and is more likely to go down the route of unnecessary medical interventions, and the biggest one of this being surgery. Early imaging results in a greater incidence of unnecessary surgeries, and I think we can all agree that this isn't a good thing. So the diagnosis in terms of a structural diagnosis isn't necessary. And this is why the overarching view on diagnosis of lower back pain is to call a lot of what we see non-specific lower back pain, because a diagnosis of a specific nociceptive signal is not necessary. It doesn't change the management plan. And in the case where imaging is involved, an attempt to make a diagnosis can actually be problematic. So essentially, someone has come in, they've had an acute episode of lower back pain, and we're terming this non-specific lower back pain. Now, that is problematic in itself, in that it can come across as being very dismissive. So if someone comes in and we go through an assessment and we say that you have this non-specific lower back pain, it almost feels like we've not fulfilled our due diligence and our duty in terms of providing that person information about the cause of this negative experience that they're currently having. So when we go through our assessment, we're trying to identify, in the case of an acute lower back problem, the potential cause. So did that person do a stressful movement, something that they're not used to, something that was potentially too intense? They lifted something that they didn't have the capacity to lift. And so then we're talking about a very direct tissue specific problem. And when that happens, we look at the type of movement. Did they bend over to pick something up, or did they try and catch something overhead where they were very bent? Did they twist? That can give us a bit of an idea about potentially the structure that is involved. And we can hypothesize with the disclaimer that we don't really know, but we can say, this is maybe the type of tissue, but at least the direction that the pain has occurred. It might be that there was a repetitive technique or repetitive position. So someone who's used to sitting in an office chair for 8 hours a day has a particularly busy period of work where their sitting volume goes up to 12 or 13 hours a day, and for several days they're in this the position which might not be a good or bad position per se. We'll talk about that later, but they've just overloaded. They've done more than they're capable of doing, and that has led to stress on a certain area. It may be repetitive tasks in sport. Someone has done a larger degree of let's say they're a baseball pitcher, and they've done twice the amount of throws, so they're doing a lot more rotation, and so they're exposing a certain area of their back to increased load. So in this case, we would assess, go through some movement assessments, see if there's a specific direction that they're painful in, and feel around the area and see if we can sort of feel for particularly sensitive structures. And then we would discuss how we go about unloading those structures. Now, if someone has experienced pain and maybe they're a couple of days after their acute pain and that acute pain is already settling, then in terms of the pain management, we might not need to do too much. If the pain isn't changing and we're still fairly on, it's maybe a day or the same day as that injury or the day after, we identify a direction of pain, then we can often move away from that direction. So if someone has pain with forward bending, then often back bending might be pain-free, and repeated back bending, so moving away from the sensitized direction, can actually help with the symptoms, decrease the pain with that sensitized direction. So that's one strategy, and this is sort of known as a McKenzie approach. So that's one strategy, one tool that we have in our toolbox is sort of repeated direction away from the sensitized direction. If there isn't a specific direction, someone might have pain in both directions, especially if it's very acute and very flared up. We can see if we can modify what they're experiencing locally. So we can use some repositioning techniques, some glides on the back to see if someone can move a little more easily in either direction. And we can use that as a manual therapy intervention. And then we can also teach that as a home exercise to give someone a home exercise tool to try and manage their pain. We can use other modalities. We can use manual therapy interventions such as massage or acupuncture or manipulation or mobilization. Often different musculoskeletal health practitioners will have their favorite tools, and that's great. If you're confident in your ability to apply a manual therapy intervention that can decrease someone's pain in the early stages, that's great. This is where we sort of start to come into one aspect of controversy, or I guess another aspect of controversy in terms of back pain management or pain management in general, is the use of manual therapy. Manual therapy throughout the world is used to treat injuries, and usually involves some sort of pressure on the painful area. There are those that believe that manual therapy, let's just talk in terms of back pain, that it is not required and shouldn't really be recommended or shouldn't really be practiced. Part of this is, especially in a public health system, that it's considered a low value intervention. So in public health systems, you're using taxpayers' dollars and people's precious time and resources to apply a treatment modality that doesn't actually infer benefit in the long term. And this is true to a certain extent. There are studies showing that addition of manual therapy doesn't actually improve long-term outcomes in lower back pain. Even with that, I feel that as a health practitioner, and for someone who doesn't practice in a public health system, who's dealing with people that are funded by private health insurance companies or self-funded, if someone comes to me having a painful experience, I still feel that there is value in decreasing that person's pain. If we're thinking about human interactions, if someone comes to me human being to human being, and having experienced musculoskeletal pain myself, even if I don't believe that it's going to impact their long-term outcome in a major way, I still think there's value in providing pain relief to that person. Where it becomes problematic is the way that we're explaining the interventions that we're using. And I think this is probably the biggest criticism of manual therapy. Some practitioners will describe what they're doing with a patient or person experiencing pain as, they're realigning their spine, they're putting things back in place, they're realigning discs, and they're correcting the position of their pelvis, or they're sort of releasing adhesions and breaking up scar tissue. None of that really happens. So we do have a separate episode on the effects of manual therapy. If you're interested in going into a little bit more detail with that, have a look at that. But essentially what we're doing with manual therapy, when it comes down to it, we're doing something that affects the nervous system, that decreases the sensitivity of the nervous system, and in doing so decreases pain. When we start to use narratives like correcting misalignment, then that can be problematic in terms of setting up someone to experience chronic or persistent pain, where they feel that when they're in those periods where they're having pain, that it must be that their pelvis is out of place again and they need to go and get it clicked back in or cracked back in, or that they've got these tissues that are adheres to one another, and they need to go and see someone to have that broken up. And that can really affect, again, the beliefs around our pain, and we've talked about that a couple of times now in terms of how that actually affects pain. So manual therapy in of itself isn't a negative thing, but when someone is undergoing manual therapy treatment, they need to have the mechanisms explained to them in an accurate and truthful way, in order for those interventions to not then become harmful.
And we also know that the effectiveness of these interventions, and effectiveness of any intervention for that matter, is partly based on the person's expectations. So if someone has had a positive experience with manual therapy or massage or acupuncture in the past, then that will bias their response towards having a positive response to that same modality in the future. And this also relates to someone's confidence in the practitioner that is administering whatever treatment it is. So if a practitioner comes across as being very confident with a certain technique, which usually happens when someone is skilled at a technique, they come across as very confident when performing that technique, then that will increase the patient's confidence in what they're doing, and therefore lead to a more superior outcome. And it is believed that it is more the confidence that comes along with being skillful in a technique than the actual skill of the practitioner that is driving those changes.
Now, so that's what we've talked about tissue-specific treatment modalities. If someone is undergoing more biomechanically related pain, so they may have a movement pattern that is either causative of the pain or has resulted as has come on as a result of the pain and is then contributing to the pain, then that's maybe something that we need to address as well. So let's say someone is very restricted in their hip range of motion, and they're doing a task that involves a combined movement. So another technical term, we're going to talk about hip extension as a movement. So hip extension is when we move our leg, our thigh, backwards, okay? So when we move our thigh backwards, that's usually coupled with a rotation of the pelvis and an extension, a backwards movement of the spine. Now, someone might have experienced a hip injury, which has caused a restriction in their hip range of motion, and then that has then caused an overload of the spine, and that has then produced some nociception that has then caused back pain. And this is why we talk, when we go through someone's history, we also want to establish previous injury history. And now, previous injury, we know, is the greatest risk of future injury. And that can be both local. It can be if you've had a hamstring injury, then your likelihood of sustaining another hamstring injury is going to be greater. If you have, like we talked about, if you have a hip injury, then that might increase the likelihood of a lower back injury because of the increased stress on that area. And then we also know that once you have an injury, your nervous system is again going to be upregulated, and so your ability to detect pain, your nervous system is on greater alert. It's searching more for areas that are under higher degrees of stress, so you're more likely to experience pain in another area. So if particularly if someone has experienced a previous injury in an associated segment close to the lower back, then we're looking at that and seeing if we can apply a specific treatment modality, whether it's exercise or whether it's specific manual therapy intervention to try and improve the movement in that area to then take the pressure off the lower back. It may be that someone is just naturally very stiff in a certain area. So let's say someone is very stiff through their upper back. Now, they've probably gone through their entire life with that stiffness and not having it been problematic. It's not a recent stiffness that's occurred. It's not as a result of a recent injury. But they might have had a lower back injury for another reason, for what we talked about before, just they've done too much too quickly, or they've had a slightly awkward movement. But now that upper back stiffness that wasn't problematic before is now slowing down the healing process because it is putting more pressure on the back. So in a normal sort of homeostatic state for that individual, the upper back isn't a problem, but now the lower back has become sensitized. So the upper back is continuing to put more stress on the lower back and sort of delay that healing process. So if that's the case, we may need to do some specific exercise intervention or manual therapy intervention for that particular area. And we go through this in basically an algorithm. We look at someone's movement. We see if they move better in one direction, and if repeated movement in that direction helps decrease pain in the painful direction, we use that as an exercise intervention. If not, we still talk about ways and discuss options for decreasing the amount of movement in the one direction. So I'm getting a little lost here, but if you're talking about pain with forward bending, if someone has pain with forward bending, and that's usually what we call a flexion sensitive problem, and that's usually associated with pain with bending, sitting, driving, those sort of tasks, then we would first of all see if the person experiences a decrease in their pain by doing repeated back bends. Right? If they do, great. We might prescribe some back bends as part of their exercise program. If not, then we'll look at how we can maybe modify the amount that they're sitting, get them in a standing desk. We might use some taping techniques to actually get some rigid support for the lower back to allow it to not go in that forward bending position. So using strategies like that we can decrease the amount of time that the person, or decreasing the number of movement cycles that a person is going in that direction. And then the next part would be, like we talked about before, modifying, using different glides, seeing if we can change the way someone moves to then take the pressure off the area. And then we would maybe look at doing some treatment on adjacent segments and then reassessing the movement and seeing if that helps. Then the next part of the assessment is working out other parts of load that might be contributing. So is that person sleeping a lot less, which would be an indirect systemic load? Have they changed their diet? Are they not consuming enough energy to match the tasks that they're performing? Are they just doing too much exercise? So it might be that someone is just overloaded. So not necessarily overloaded in terms of direct tissues. So it's not that they've done a certain amount of back stressful movement. It's just that they've done too much overall activity. So the whole nervous system is overloaded, and that's why they're experiencing their pain. As we talked about before, it might be psychological stress. Now, all of this might be associated with increased nociception, but the nociception may only be a smaller factor in the overall stress on the system that then is producing a painful response. So we need to talk to the person about all the things that are going on, and in particular all the things that are different in and around the time when they experience the pain to their normal life. Are you sleeping less? Are you more stressed? Are you eating less? Are you eating more? Have you put on weight? Have you lost weight? And going through and seeing what we can change, and then we try and manage that. And so all that we assess the acute load, and then we try and settle down, use what tools we can to settle down that pain, and then we start to build them back up. And we just go through a graded exposure to the type of loads that person needs to undergo to need to be able to tolerate to do their normal day-to-day tasks, whether it be just sitting for a certain amount of time or whether it be playing high-level sport. We grade their activity levels up, and some of that might include specific exercises to mimic the activities that they're going to be doing, and then just make that more and more challenging until we can get them back to the point where they're safe to return to their normal activity. So what about the person who has persistent or recurrent low back pain? And often this goes in chronological order, acute low back pain, and then another episode, and then it starts to become chronic. So you can have, chronic intermittent back pain. So, at times you don't experience any pain, and then maybe 4 times a year you have these, acute onset that might take a week to get better. What's happening when we have someone who's going through that experience? We've talked already about some of the things that can contribute to this. Beliefs around what's going on in that person's body, the sensitivity of the nervous system, and that might be general sensitivity, or it might be sensitivity to a certain direction, or certain movement pattern. So someone has pain with bending forward, they then start to develop sensitivity associated with that forward bending. And in the cases of sort of chronic and persistent pain, it can be a very psychologically driven problem, in that someone can even just think about bending forward, and they'll already start to experience pain. So these are all things to take into account. We see changes in movement being a massive part of this. So once someone has pain, then they may start to move in a different way, even after their pain has reduced or diminished or resolved. Some of this may be conscious, some of it may be subconscious. So if someone comes and sees me and says they have pain with forward bending, I might have a suggestion or recommendation of avoiding forward bending, but only for a short period of time. However, whether this is the fault of health professionals or for whatever reason, someone may just continue with those recommendations indefinitely. So there are some health professionals, I'm sure, out there that have given bad advice in terms of long-term avoidance of certain movements. But then there's people that may have recovered from the acute stage of a lower back issue and have been told in that acute stage to avoid forward bending, and then they just assume that forward bending was what caused their pain, so they're just going to avoid that forever. Now, you might think, that might be a good strategy, but it's not really. I mean, it's likely impossible that you're going to be able to avoid that certain movement pattern forever. And what happens if you're avoiding a movement pattern which has previously been normal for you, then you lose the capacity to be able to perform that movement pattern. So if you're not used to bending forward, your back loses the capacity to bend forward. And so when you do bend forward, then the ability of the back to be overloaded and trigger a nociceptive stimulus is then increased. And then this can just gradually continue to increase over time. And so when someone does recover from an acute lower back injury, it is important that we do try and make sure that they revert to their normal movement patterns, to normalize their movement as much as possible. And if there are deficiencies in the way that they move, rigidities or lack of range of motion, then we try and address that. But building up capacity to tolerate movement is an important factor as well. So again, if we're going to stick with the forward bending movement, we might have someone practicing a forward bend under a certain amount of load to develop their ability to be able to sustain that type of loading. All in all, I mean, if you considering acute lower back pain, it's probably best just to consider it as almost like a common cold that may drag on a little bit longer than a cold and may be a little bit more uncomfortable, a little bit more severe. But it's not something in general that we need to be particularly worried about, and especially from a structural perspective. Yes, we want to try and make sure that the person has reverted back to their normal movement patterns, but we don't need to be particularly worried. And like I've said before, we don't need to go about imaging. I'll sort of make a transition now into talking about chronic lower back pain. And at this point, I'll sort of talk about where imaging is useful. In an acute sense, I think if someone has undergone a significant amount of trauma that would make the clinician in their best judgment based on their clinical experience suspicious of something like a fracture, then I think that we definitely need to be going down the route of imaging to rule out a fracture, or to try and accurately diagnose any bony damage there. In terms of more persistent and chronic pain, there are specific diagnoses that are important to identify. In the case, let's say someone is a young athlete that is undergoing a lot of extension. So as we know extension as back bending. So the typical ones here, like gymnasts, fast bowlers in cricket, where they're getting repetitive extension, we can have stress occur on a certain part of the back called the pars interarticularis. Again, please don't remember that. And this can cause a stress fracture. And imaging in this type of condition is really important because the stage of the fracture or the stage of the degree of bony damage will dictate what type of treatment intervention we apply. So in the early stage of bony stress in these type of athletes, there is still scope for that fracture to heal. Once it's gone on for a certain period of time, the capacity to heal is no longer there. Now, that doesn't necessarily mean that someone can't go back to activity and manage the condition and be able to manage it without pain. It just means that we can't really heal the bone, and it's probably the likelihood of it causing problems long term is probably greater. So if someone is in the stage where they can still undergo some bony healing, then we do want to try and promote that. More systemic conditions. So if someone is experiencing a lot of night pain, morning stiffness, and it takes a long time to get better, then they may have a systemic inflammatory condition like ankylosing spondylitis. And the management for something like this will again be different from more of your non-specific lower back pain. So that's when diagnosis is important. And this is, as physiotherapists and other health practitioners, we're trained to sort of pick up the type of symptoms that would be suggestive of this sort of condition and refer for the appropriate imaging. Neural symptoms. Now, this is sort of going to take us down another little rabbit hole, but often lower back pain is accompanied by pain in the leg. Now, there are a number of different causes of this, and we've done previous episodes and posts regarding this. The most common cause of leg pain associated with lower back pain is what we call referred pain. So this is when we have nociception coming from somewhere in the back, going up to the brain, accompanied by other nociception, other nerve fibers from around the area, converging in the brain, but the brain not having a perfect map of what's going on. We know maps aren't always perfect. I'm sure, well, I know that people have failed to find our clinic here because Google Maps has, taken them somewhere else. And the brain can do the same thing. So even though it's been given signals from the lower back, it's interpreting those signals as coming from the leg. Okay. And if this is the case, when we assess the nerves, those assessments will come back negative because the nerve itself, or at least the sciatic nerve that would travel down in that direction, is not directly involved in the problem. So it's essentially a mapping error. By the same token, we can have what we call neuropathic pain with central hypersensitivity. Now, this is going more to the other end of the scale where there's minimal tissue damage, but there's an extreme degree of sensitivity in the nervous system. And that will tend to cause symptoms such as like itchiness or creepy crawly type symptoms that are very sort of divergent from your normal like sciatica as people would describe. So this is associated with more of an upregulated nervous system, and these type of problems are not likely to respond to physical management and sort of biomechanical approach. These type of issues respond more to a very graded exposure to load in combination with equality pain education. We can then have a sensitized nerve. So this is where there has been an inflammatory response around the nerve root. So where the nerve exits the spine, we can have maybe a disc injury, maybe a joint injury, something that causes inflammation in the area. And essentially the inflammation manages to seep its way into the nerve. And so the nerve then becomes inflamed. And when the nerve is inflamed, it's sensitive to stretch. So if you have a peripheral nerve sensitization, you lie on your back and you pull the leg up towards you because you're stretching out the sciatic nerve. And I'm just using sciatic nerve here as an example. The femoral nerve at the front is another nerve that can be injured by the same sort of process. But that nerve becomes very sensitive to stretch, and that reproduces the pain. These sort of conditions will usually resolve in about 8 weeks if the original source of the inflammation also subsides. We can increase or decrease the sensitivity of this condition using some specific nerve glides. So we would actually get the individual doing some exercises to move the nerve, to desensitize the nerve, to increase blood flow to the area, to decrease pain, but usually doesn't speed up the recovery per se. And then we can have compressed nerves. Now, compressed nerves can happen transiently, and when they happen transiently, so by that I mean they come and go. Someone might experience symptoms of nerve compression, which are usually numbness. And sorry, I should go back. A sensitized nerve will typically present with symptoms such as tingling and pins and needles, whereas a compressed nerve will present with signs like numbness and weakness. Now, if a nerve is transiently compressed around a muscle, and one muscle is the piriformis muscle, which is in sort of the buttock, which in many individuals lies very close to the sciatic nerve. And if that is increased in tone for some reason, that can push against the nerve and cause some neural type symptoms in the leg. But those symptoms usually come and go. We can usually reproduce them by positioning the person and contracting that muscle, or by pushing around that muscle. When someone has ongoing numbness and weakness, that's usually a sign of compression around the spine. And this may be the result of a large disc herniation, but not always. So if you have a scan that shows a disc herniation, disc protrusion pushing against a nerve, it might not, there's a fair chance that it might not actually cause these symptoms of compression. But when we do have symptoms of compression, we do want to find out if these symptoms are worsening over time, if there is a sign of compression on an MRI. So this is really the main reason, and probably the only reason why we would want to get an MRI to look at the structure of the disc, is if we're getting numbness and weakness in the legs that we assume is originating in the spine, then we want to have a look at that. And if it's worsening and our non-operative interventions are not halting the progression, then that is when a person may benefit from a surgical intervention to surgically decompress the pressure on the nerve and to allow that nerve to be freed up and to undergo a sort of normal regeneration. Okay, so that's the time when we would want to look in regards to the specific diagnosis, when we would want to look at the structure of the disc. Now, probably the greatest value of medical imaging is in terms of ruling out non-musculoskeletal causes of pain. Okay. Now, this is another cause of nociception. So we've talked about how the nociception might be coming from disc, joint, muscle, bone. That nociception may also be arising from a visceral source, or it may be arising from something like a tumor. All right, so that is when we really want to utilize our imaging. So again, as health practitioners, we're given skills to try and identify cases where someone might be likely to be experiencing pain that is originating from a structure, from a non-musculoskeletal structure. And so if this is the case, and if someone's not responding to the normal treatment, then that's when we can really use our medical imaging to identify a potentially sinister cause of pain. And hopefully, if we were able to identify that, identifying it in time, that person can then seek the necessary care and treatment, so that that pathology has as little impact on their life as possible. Now, that's sort of what we think and understand from an evidence base. In terms of my own perspective, I think that if someone is experiencing sort of persistent lower back pain, having an MRI to look at the loading patterns, because if you look at, let's say you have a pair of shoes, you run a lot in those shoes, you can see the wearing patterns of those shoes. You can see where that person puts more pressure, and that can give you a bit of information about how they use their body when they're running, which may relate to someone who has a running-related injury. Now, I think that we can sort of glean some similar information by looking at imaging. So if we're looking at sort of the bony structure, we can have an idea where someone is loading in a particular movement pattern. Let's say if someone has done a lot of heavy resistance training over a certain period of time and they are loading at a specific level, that may be relevant to where they're experiencing their pain. I would be very careful when I'm going through these findings with a person, in terms of making the distinction between identifying loading patterns and identifying structural pathology. Because again, unless someone has numbness in the legs, we're not too worried about what's going on structurally in their disc, whether it's actually causing their pain. But it can sort of give us a little bit of biomechanical information about how we might go and optimize that person's movement patterns. So let's say someone has developed a chronic or persistent lower back pain. How do we go about managing that person? So we've obviously ruled out a non-musculoskeletal cause of their problem. We've assessed for red flags. The person doesn't have any neurological symptoms, and they may have back pain, or they may have leg pain that is referred from their back. Now, as health practitioners, it's our duty to apply what we call evidence-informed practice. Now, I like the term evidence-informed rather than evidence-based. Now, there may be criticism that that slight change then gives me the freedom to acknowledge evidence, but ignore it, and then just do what I feel is most appropriate. But I think for someone like me who's been working in this area for almost 2 decades, has studied a number of different assessment techniques, treatment techniques, has seen hundreds, probably thousands of people with lower back pain, I think it would be irresponsible of me to ignore my personal experience and base my treatment of people experiencing lower back pain purely on the trends that are identified through studies of large homogeneous populations of people. So when we talk about managing chronic lower back pain, I'm going to start by talking very globally and then start to move inwards in terms of how we really apply a patient-centered or an individual-centered model. If you want an easy, very simple approach that for the majority of people is probably going to improve chronic lower back pain symptoms, the recommendation would be to be healthier. Okay, do something that makes your life healthier. Okay, because we have evidence that if someone exercises more, that is likely to decrease their pain. If they sleep more, that's likely to decrease their pain. If they decrease their psychological stress, if they improve their diet, if they improve their hydration, if they have more meaningful relationships with people in their life, if they have good social support and they have frequent interactions, positive interactions with people, they're likely to decrease their pain. So I think that is a good start. I think that when you address someone's lifestyle, trying to encourage better health is always a good option. And obviously, being healthier doesn't just benefit back pain; it benefits all areas of our health, and improves our quality of life. Stop smoking if that's something that's relevant for you. Drink less alcohol. All these things may have a positive effect on pain, but they may not. Okay, so you might increase your sleep from 6 hours a night to 8 hours a night. Can I guarantee that your pain will decrease? No. I think that it may have a positive effect, but a positive effect needs to be of a certain magnitude to actually create a change in that pain experience, and it may not be sufficient. It may be completely sufficient. That might be all someone needs to do, and that's why what we call what we do a practice, because we're constantly practicing, we're constantly trialing. Sometimes it's trial and error, and sometimes it's just seeing what works for that individual. So exercise is an important part of lower back pain. The majority of people will improve lower back pain symptoms if they exercise. Right? What about if someone's you're getting chronic pain and they're doing high level sport 10 times a week? Do we recommend that they do more activity? Is that likely to help? Probably not. And so everything needs to be viewed in context to that individual. So if we know that, a lot of things seem to help a little bit, but nothing's really, that much better than anything else, which is what comes across in the research, that, exercise helps a bit. Manual therapy might help a bit in early stages. Some exercises are a little better than others, but, nothing that we don't have this clear specific magic fix for chronic lower back pain. So as a practitioner, you then need to find a system that works for you in terms of improving outcomes. And a lot of this is through trial and error and continued education. So for me, I always come back to that load model. I look at the load that someone is under, and I try and work out from that story where I think that person's load is greatest and what's contributing to their pain. So if it's a biomechanical issue, do we try to improve their biomechanics? We talked before about how someone's movement patterns may change in the presence of pain. We know that the nervous system is all about protection, and if it's trying to protect that individual by changing their muscle tone, which then leads to differences in movement pattern, we need to progress that person to the point where the protection is no longer to the degree where it is impacting on their pain. Ideally, we want to get to a stage where that person is no longer thinks about their back. If you don't have back pain, you're not thinking about your back. If you do have back pain, you probably are, and that is contributing to that back pain hanging around and becoming chronic. So we use different strategies, like awareness-based strategies and different things to try and enhance our relaxation to try and get that person moving as normally as possible. For For some people, we might, if we feel that it's a very centrally driven problem, that there's stress contributing to it, we look at maybe stress management strategies. The way that we use exercise may differ based on that person's presentation. So if the person has a large degree of central sort of nervous system sensitivity, then we can use exercise to try and decrease that sensitivity. This may or may not be someone who's experiencing those symptoms we described before, like the creepy crawlies in the leg. That's very indicative of central sensitivity. But someone might just be overall upregulated, and that's impacting on their pain. For that person, we start at a very low level of exercise, and for them, it's not so much about the specific exercise. It might be something that they enjoy. It might be something they can do with others that increases their adherence to that exercise. But more important is the dosage. It's how much they're doing. We try and find a baseline where we can do an amount of exercise that doesn't flare up the symptoms, and then just gradually increase that exercise. For others, especially if they're more athletic, the exercise might need to be quite specific. So if someone is performing a task where they're having to use a lot of leg strength and they need to be able to produce force through their hip extensors, and a lack of strength through there is causing stress in the back, then we do a very specific strengthening program with specific goals in terms of strength and parameters and objective measurements to make sure that they are getting stronger in that area. And it does become a very sort of biomechanical focus. If someone has a specific direction of pain, so we talked about direction specificity with acute pain. So someone comes in, forward bending is painful, back bending is not. The same thing with a persistent or chronic pain. And so we can potentially change that person's pain experience by getting them to maybe for a short period of time avoid the painful movements, and then start to, over time, gradually reintroduce those painful movements as their sensitivity decreases. Or the same strategies, that same McKenzie approach in terms of repeated direction in the opposite, repeated movement in the opposite direction, may help with persistent pain cases as well. So those are sort of different strategies that we can use there. We talked before about building up people's capacity to perform certain movements. Now, some of this is physical capacity. So we need to actually train the tissues to be able to tolerate stress. We need to train the tissues to be able to be loaded without the local nociceptors being fired. So again, this is all about graded exposure to a task. And then we also need to decrease the psychological and the cognitive barriers associated with a particular movement. So if someone is particularly fearful of movement, we might not actually be able to start performing a certain movement. We might actually have them imagine that movement and just get used to being comfortable imagining performing a certain movement. Again, forward bending. If someone's really fearful of forward bending, we might get them practicing forward bending, and then we might get them performing a lumbar flexion movement, so that forward bending movement in a different position. So one I often use is have someone on their hands and knees, rocking their hips back to the heels, which produces lumbar flexion, but then while they're doing that, have them imagine that they're standing up and bending forward. So they're cognitively retraining that process, but in a less threatening environment. And then we would progress back to the activity that they want to do. And so, again, trying to decrease that element of protection as much as possible. And often some of this increased muscle tone may be associated with an increased focus of the nervous system on that area. And this leads to a decreased capacity in the distal limb. So imagine you have a normal functioning system. Your feet and your ankles and the knees are supposed to function in a way where they're handling a lot of the load so that the lower back isn't being overloaded. When you have a lower back injury, all the nervous system's focus becomes on the lower back, so that you sort of start to tense up in that area, and that contributes to the pain. So some strategies might be to get a person using their ankles and using their hips and knees in a way combined with lower back movement to see if we can actually change the tone in that area. Some strategies that I've used in the past are having someone bend forward, they experience pain in the back, and then have them maybe squeeze something between their knees. So they're firing different muscles, they're using different strategies, and it can make a big difference to their pain. Or even just getting them to come up onto their toes slightly. So now the focus of the nervous system is not on the back, but on the feet. And so in doing that, you're decreasing some of that tone and you're unloading some of that stress through the lower back. And strategies like these can be very effective. But like I said before, this is where we use a more individualized approach based on a lot of different factors in terms of our assessment of that person, of their story, of their movement, and then combine it with more of the global, holistic approach to sleep, general exercise, and just life hygiene in general. Now, do we need to eliminate fear avoidance altogether? Not necessarily, and it depends completely on the goals of that person. So take myself, for example. I used to do very heavy resistance training, and I injured my back performing a deadlift on 2 occasions. And had fairly severe acute lower back pain. Now, does that mean deadlifts are bad? Please no, don't interpret it that way. Deadlift is a fantastic movement for building up capacity through the lower limb and building up confidence with functional tasks involving lifting things from the floor. But for whatever reason, whether it was a programming error, whether it was a general fatigue error, I had a couple of lower back episodes. Now, structurally, would I be able to get back to heavy deadlifting if I want? If I was a competitive powerlifter, could I program myself to get back to that task? Absolutely. If I think about trying to deadlift 2.5 times my body weight that I was doing, so depressing to think now, maybe 7 years ago now. If I think about that now, that's a fairly confronting thought. I don't feel comfortable with that particular movement pattern. But for me, do I need to be deadlifting those sort of numbers? No. At this stage in my life, I want to be strong. I want to have general strength. I want to have physical capacity that enables me to live a healthy life, but also participate in martial arts. But I don't need to be lifting that heavier weight. I can lift very heavy weights with a single leg deadlift, and that's an exercise that I really enjoy and have no fear and apprehension about. Even though I'm lifting more than half of what I was lifting with 2 legs with 1 leg, so I'm putting a lot of load through my hips and through my lower back as well. But it's just the movement pattern itself of a 2-legged deadlift that I just don't feel comfortable with. And for me, that's not a problem. I can pick up my kids from the floor. I can pick up if I need to move heavy boxes around my house. I can do all that, but it's just at a certain level, at a very high level of lifting-based task. I do have fear avoidance, but that fear avoidance isn't going to be problematic in the foreseeable future. So that's an example of where you might not need to take that person back to that previous level of activity, and that then leads into a discussion around life goals and athletic goals and those type of things as well.
What about the role of manual therapy in chronic pain? There's definitely a role, in my opinion. We can use manual therapy interventions to make changes in pain. We know that manual therapy can decrease pain, and that can do a number of different things. It can allow for someone to engage with other interventions that we know are going to be helpful. So if someone's pain is reduced through a manual therapy intervention, they can exercise. If they weren't able to exercise before, it may allow them to exercise, may allow someone who's already exercising to exercise at a higher intensity, therefore stimulating greater adaptation and contributing to their overall improvement. We know that with things like massage, that can directly address psychological stress. So that can be used to address the psychological aspect of load. And therefore, as we get a decrease in that psychological stress, the overall load is decreased, and therefore they're likely to decrease experience a decrease in their pain. There's also a more complex human interaction that comes along with manual therapy when we're applying touch. There is that stronger connection, And there's a strong sense when someone is laying their hands on you that they're providing care, they are taking a meaningful interest in your health and wellness. And that alone, even if we take away the physiological effects of that intervention, that alone can be a powerful tool in terms of decreasing the sensitivity and decreasing someone's cognitive barriers that might be associated with their pain. And someone might need semi-regular manual therapy going forward. It might just be what works for them, that they are doing all the things that they need to be doing in terms of improving their general health, improving their capacity through exercise, doing some specific exercises that they need to be doing. But they find that semi-regular manual therapy seems to be a positive adjunct in terms of keeping their symptoms at bay. And then if someone is, participating in physical activity and sports, in high-level exercise and doing that frequently, then things like massage can be useful for recovery and to allow that person to continue functioning at that high level. And so some maintenance massage and maintenance mobilizational manipulation can be a useful adjunct, likewise for a high-functioning individual. But again, as we talked about before, in regards to manual therapy for acute lower back pain, it needs to be applied with the correct narrative and the correct explanation as to the mechanisms by which these manual therapy interventions are effective. I'm going to move on now to talk about posture. This is where we start to get into a little bit more of some of the controversial topics around lower back pain. Does bad posture cause back pain? Probably not. The evidence that we have seems to indicate that resting posture in both standing and sitting is not directly associated with lower back pain. Now, does that mean it's not relevant? No, not at all, of course. It all comes back to how someone presents, how they describe their story in relation to their pain, and what we can glean from that story in terms of what might be aggravating their pain and what might ease their pain. So if someone has pain with prolonged standing, we look at how they're standing. So like we talked about with the biomechanics example of someone who has limited hip range of motion, they might have had limited hip range of motion for forever, but now they have a sensitive back for whatever reason, and the limited hip range of motion is placing the same amount of biomechanical stress on their back, but because the back is sensitized, the limited hip range of motion now has a greater impact on the possible chronicity or ongoing nature of their pain and the, delay and prolonged time to healing. Now, the same thing could be said for standing. If someone stands with a quite a big arch in their back, that might be the way they've been standing their whole life, and that in and itself isn't injurious. But now if someone has a back issue and the way that they're standing is now sort of compounding that, is causing that to remain sensitized, then it might be something that we need to address. And it might be something we address just for the short term. So for that person, we would have them standing, assess their degree of discomfort while they're standing, then have them try to modify their standing posture. So if they are standing with quite a big arch, we might have them correct that arch or try to minimize that arch, I should say, and then note any change. And if it improves their symptoms, we will use that as a strategy to try to decrease the sensitivity and allow their condition to settle. And the same thing goes for sitting posture. If someone has pain when they're sitting, we would adjust the way that we'll assess the way that they're sitting. And if there's things that we can adjust, we would adjust that and note for a change. Now, what is interesting is that what a lot of people assume is a bad posture and one that would contribute to lower back pain is often not the case. So I think most people intuitively feel that a slumped, rounded, as we know these terms, flexed posture is something that may cause pain. And with some people, yes, they either because they've been sitting too much in that position, or maybe the sitting position, the flex sitting position, combined with another flexion type of like a loaded task, has caused some pain. And they now have sensitivity while sitting with the spine flexed. For that person, we may need to change their posture again, maybe just temporarily, have them sit with a lumbar support. They may need to sit with a jacket with a built-in lumbar support. Visit lumberjacket.com if you're interested in such a product. I think everyone is aware of my conflict of interest there. But again, that product, even though I make money off that product, it's not going to be suitable for everyone. So if someone has pain with being in a slumped posture and sitting up straight relieves the pain, even just in as an assessment, we might work on strategies using a lumbar support, using a different sitting posture, changing the way that they sit temporarily to allow their condition to settle. And if that's something that works for them, they feel comfortable, it might be something that they want to do long term. Or once the sensitivity settles, they might revert to their normal posture, and we tend not to be worried about that. But the opposite might be true. So whether it's because of the general overactivity in the lower back muscles that occurs when someone has pain, or whether, and I think this is probably more common, the cognitive intuition of most people when they have pain is to try to sit up as straight as possible. That in turn can start to cause pain. So if you're sitting up straight, your lower back muscles are often working quite hard to try and keep you in that position. And as we talked about before, if you have your lower back muscles contracting at an excessive amount for an excessive amount of time, then that in itself can become a nociceptive factor. And what we find is, someone might have an acute, structural issue with a disc or a joint. That's their main source of pain. But then they do things to try and offload that structure by sitting up straight. And then they develop secondary nociception. And the primary source of nociception, let's say it is a disc, that settles down, that's healed, but they've got this ongoing muscle spasm. And we see this quite a lot. And so, numerous times we'll have someone in the clinic looking at their sitting and they're bolt upright. We'll then try to get them into a position when they're more relaxed. So sitting back into a chair, allowing their lower back to relax. And what we've found is there's many people who have found that sitting in a more slumped, relaxed position actually feels better on their back. But they persist with trying to sit up straight because they feel that is the right thing to do. And it's almost, feels like sort of cognitive dissonance in a way. But I think it speaks to the power of, societal influence and, the messages that people have interpreted over the years in regards to things like posture and pain, that it is such a overriding principle that you need to sit up straight to look after your back, and it's often not the case. So changes to posture really need to be done on an individual basis. Some people need to round more, some people need to arch a little more, and it's sort of based on how you respond to those different positions. Now, in terms of the optimal type of exercise, that's really the exercise that you're most likely to do. The research that we have hasn't showed a great deal of difference amongst different types of exercise. There are trends towards different exercises which I think highlight the benefits and elements of certain exercises that may be beneficial. So Pilates actually outperforms a lot of other exercise modalities when it comes to back pain. Now, why is that? Is it because Pilates helps strengthen the core muscles and provides stability to the lower back? We'll go on to talk a little bit about core stability. That may be a reason, and for some people that may be relevant. I think the more likely explanation is that Pilates is considered compared to maybe higher intensity resistance training or other forms of exercise a little bit gentler. And so when people are in pain and they're hesitant to engage in physical activity, something that is thought to be lower intensity is probably going to have a higher rate of compliance. So people are more likely to engage with that type of activity because it is just generally less threatening. And there's also an awareness aspect and people sort of focusing on muscles in and around the area where they're experiencing pain, and that alone is a useful element of rehabilitative exercise. So if you carry that over to other forms of exercise, whether it be of general resistance training or aerobic training, I think us as clinicians need to again focus on the positive elements of successful exercise types and trying to enhance that. So if it is the fact that a lot of exercise is too demanding initially for a client, obviously we want to build a high level of capacity for the client, and what that means will depend on the individual client. But perhaps using a lower intensity strategy might be an effective approach for a lot of people. But in the end, it's just what you enjoy, what you can do that feels good, that feels like it's a good fit for your physical capacity, and something that you're likely to engage in for a long period of time. And if that changes over time, then that's great as well. If you're trying a number of different activities throughout your athletic lifespan, that I think has a lot of positive benefits in and of itself. Now I'll talk a little bit about core stability.
Forget everything you thought you knew about ab workouts.
Done.
This ab workout is specifically designed to strengthen your core.
The whole idea of core stability sort of started around it became popularized around the late 1990s. There was a particular study out of a group of researchers from Queensland University in 1998 that showed that there were some changes to the muscle activation in the deeper abdominal muscles when people had back pain. And like I mentioned off the top in regards to pain education, often the pendulum swings far too far. And this happens where the results of studies are misinterpreted or just over applied in contexts where they may be not as relevant. And the researchers who published that paper have sort of since come out and said maybe those findings aren't as relevant. I think with everything that we've talked about, it needs to be context specific. So if someone has had trauma to an area, say if someone has given birth to a child, we know that the core muscles are going to be affected. They've undergone a massive amount of trauma and they will require some retraining. Often when we experience back pain, the activation of those muscles, the deeper muscles in our abdominal region are impacted. When we have back pain, it's the chicken or the egg. Is the decreased muscle activation a result of the pain, or is it causative? If it's a result, which is often what we think is happening, that the muscles aren't functioning as well because there's pain in the area, and that's causing, again, another protective response. And if we can decrease the pain from whatever means we use, we can often optimize muscular control. Now, for me, I base my approach to this on symptom modification. So if I have someone perform their painful movement and I'm able to modify that pain using forces through their back and through their pelvis that I can apply with my hands that mimic the forces that the core muscles would produce, and they have a positive response and that decreases their pain, then that for me is or maybe a justification to include some deeper abdominal muscle strengthening in their program. Now, the effect of this, whether it's actually improving the control there, or whether it's just a way to create buy-in with that individual, that if I can change your pain temporarily doing this. We know there's muscles that also do this. Let's train them. And maybe it's just the fact that they're getting some loading by contracting those muscles, and it's a very low level loading. That just allows them a point of entry into an exercise program. I honestly don't know, but that's generally how I approach the concept of deeper abdominal muscle training. Now, that's one aspect of what we think about core stability. We then have more of what we call like a Stuart McGill approach. So Stuart McGill is a biomechanics researcher from Canada who has been, popularized for you focusing on limiting the movement at the lower back through sort of strength and endurance exercises to decrease load on the spinal structures. Now, again, whether his approach is one of is actual a biomechanical approach where he's building muscular control and muscular strength that actually offloads the structures, or whether, similar to the Pilates, he's training muscles in and around the area of the sensitization where that person is experiencing pain, and by doing so is decreasing the sensitivity associated with load in that area. Either way, again, the mechanism I don't think is as important as it's often made out to be. But I think there's definitely justification for using direct abdominal and lower back exercises to get direct load in that area to desensitize the area.
So the other big player in this space around that time was Stuart McGill, who was a biomechanics professor from Canada. Now, Dr. McGill based his approach around stability of the lower back in a similar way to the Australian researchers, but not so much focusing on specific muscles, more so focusing on stabilization and restriction of or limitation of movement around the lumbar spine. Now, his thoughts on the specific degree of restriction has changed over time. I think what he is aiming to get across with his teachings is that we want to try and limit end range movement where possible, and he has proposed doing this through stability based exercises where we are trying to restrict the movement at the lumbar spine. So typical sort of exercises like planks and those type of things where we're training the ability to not move into extension or side bending, or stabilizing the midsection while moving from the other limbs, from the hips and shoulders and things like that. And I guess the way that he's approaching it is that we want to try to restrict potentially harmful movement or movement that may become harmful with sufficient repetition. And we're developing the muscular capacity, in particular muscular endurance, to prevent this from happening. Now, again, I think that there's a lot of people that have done well with this approach and with his training programs, and I use many of the exercises from his programs in my own exercise prescription. But again, the mechanism, I don't believe it's necessarily, or at least primarily, one of stability. I think it's, again, inducing load through that area of the spine that is affected, that is sensitized, or that area of the body that is sensitized, having a desensitizing effect, and just developing someone's confidence in terms of using that area of the body. So once you develop strength and endurance, that has a strong psychological effect as well in terms of your confidence to be able to use that part of the body under positions and activities that involve stress.
Now, from a biomechanics perspective, if someone is performing a certain task and they don't have the strength to perform that task, now whether that's in the abdominals, whether that's in the lower back muscles, or whether it's through the hips and legs, it's all comes down to assessing the task that person needs to be able to do, how that relates to their pain. If it's causative of their pain, then improving their ability to perform that task by optimizing their strength and endurance and power. It makes sense as an intervention intervention. Can someone have too much core stability? Yeah, absolutely. I mean, whether it's they have too much stability or they just have too much activity. We can often find that people are just sort of bracing through their abdominals. We want to, when we talked about before about training the muscles around that area to try and desensitize the back, that's all good, but someone needs to have the ability to relax as well. So you don't want to be able to do a plank for several minutes, but then walk down the street, planking at the same time. That's not really an effective movement strategy. And the amount of muscle activation you have for any task needs to be specific for that task. So if you're going to lift a heavy amount of weight, you need to have a lot of contraction through a lot of different muscles. But if you're doing a lower level task, you shouldn't really be bracing through that task. And this goes back to what we were talking about before about posture and sitting, that if someone is too contracted and is using their abdominal muscles in an excessive way, whether it's the outer abs or the inner abs, that can be causing problems in it itself. So I think core strength, abdominal strength, stability training definitely has its place. We do use it with a lot of our lower back patients, but I don't think it's necessary for everyone to be doing, and I think it should probably be cautioned against for certain individuals where their ability to actually relax and get away from that contracted position is less than optimal. We'll move on now to strategies to reduce the incidence of lower back pain. We'll start with sort of posture and ergonomics. So we talked about how we would address someone's posture if they had pain with a certain posture. Let's say sitting. But in terms of general recommendations for sitting posture, the main thing that we recommend is just to vary the posture as much as possible. So the best sitting posture is your next sitting posture. It doesn't matter how perfect, how neutral your spine is, or even how sort of tense or relaxed your spine is. If you're in that same position for a long period of time, there is a higher chance of having nociceptive stress from that area, and therefore a higher chance of pain. So in terms of sitting, we want to try and take advantage where we can of switching our positions, and if we can switch from sitting to standing, fantastic. But I think that variability really is key. And the same thing with standing desks. Is standing desks the panacea for prevention or treatment of lower back pain? No, but it can be a viable alternative. It can induce a lot of variability in spinal position. And I think also when we're standing up, we tend just to be moving more. We get those little micro movements, throughout the day as we're standing, and that can be really beneficial as well. And we do know that standing does decrease all-cause mortality. That's not what we're talking about today, but there are other health benefits associated with standing. However, if you have a extension-sensitive spine, whether it's in an acute sense or a persistent spine that doesn't like long periods of standing or lying down, then it's probably not going to be the ideal intervention to start with, but it can be a tool that you could use to gradually increase your spine's tolerance to being in that position. Lifting, do we need to keep our back perfectly straight and lift with the legs? Probably not. Based on studies that we have, your lifting technique doesn't necessarily predispose you to pain. What usually happens is that people aren't used to lifting a certain load, and then they go to lift, and it just overloads the system in that acute event, and brings on a painful response. But I think that basic guidelines in terms of keeping a load close to you makes sense. And if you are going to be doing a lot of lifting, I think it makes sense to try and work on a lifting technique. And if you are used to being in the gym and you have done squats and deadlifts and you're comfortable expressing load through your hips while stabilizing through the lower back, then I think it makes sense to lift with that technique. If you're doing a lot of lifting, I would try and build up to it, because you don't want to lift something that's too heavy too quickly. You don't want to do too much too quickly if you can avoid it. And yeah, if you know that you're going to have to do some lifting for a prolonged period of time, if it's part of your occupation, again, build up to it, but you might benefit from some additional complementary strength work as well. One common sense recommendation is to avoid lifting after you've been sitting down for a long period of time. So if your back is in a flexed position for a long period of time, that's probably going to be a little bit more sensitive to having a rapid amount of load going through it in a flexed position as well. In terms of exercise, specific exercise, this again is an area of controversy. The main areas of debate are the prescription of flexion-based abdominal exercises and also the lower back position that one assumes when performing compound movements like squats and deadlifts. Now, in terms of the first point, we can elicit a contraction in our abdominal muscles by flexing the spine. So that basically means bringing the chest down towards the front part of the pelvis. Or we can, and this is just talking about the front part of our abdominals, or we can induce a contraction by having to resist the act of extension, so moving back in the opposite direction. Likewise with rotation, we can induce a contraction of our oblique muscles by rotating, or we can resist a force by which we're being rotated. So we call this an anti-rotation, anti-extension exercise, and then side bending as well. So we can bend side to side, or we can resist a force, whether that's a weight or our own body weight in a movement like a side plank, pulling us down to the side. So there's different ways that we can induce a contraction around the abdominals. Now, we talked about Stuart McGill before, and Stuart McGill has been one, I guess is the main person who popularized the idea of avoiding loaded flexion abdominal exercises. And his rationale for this was that in his experiments that he'd performed with pig models, he'd basically applied a flexion loading cycle to pig spines and seen that after a certain number of flexion cycles, this would cause damage to the discs. And it sort of loops around to where we started off, that first of all, does that happen in a human spine? We don't know, because no humans lined up for that experiment where they were put through multiple flexion cycles to see if their spines exploded. It might, biomechanically, you can sort of justify it. It makes sense. Now, those were cadaver models, and an argument is, in an actual biological human model, would the flexion cycles have the same impact, the same effect on the discs, given the sort of recovery and regeneration processes that happen in biological tissues? Maybe not. At the moment, we don't have longitudinal studies where we have people that perform higher amounts of flexion, whether through activity or just through their daily life, and how that impacts imaging findings later on. I think that research will come out eventually, and we'll have solid statistics. But at the moment, we don't really know. And we also know that disc pathology isn't necessarily related to pain. And to give you a basic example of those, a flexion exercise would be something like a crunch or a sit-up. An anti-extension exercise, so preventing that movement in the opposite direction, would be something like a plank. A lateral flexion exercise would be like a weighted side bend. An anti-lateral flexion exercise would be something like a side plank or a farmer's walk, where you're doing a dynamic movement, you're walking forward, but you're using a weight that's pulling you down and you're resisting that movement. A rotation exercise would be something like a twisting motion using a cable or a band. An anti-rotation exercise would be something like we call an anti-rotation press, where you're pushing a band out in front and resisting that band pulling you around. So are we then sort of justified in saying that people can safely perform these loaded abdominal exercises? And this is something I've been grappling with for a long time. Yeah, I, as many members of the fitness industry and rehabilitation industry, probably 10 years ago, there was a strong movement away from any sort of loaded lower back movement. You come today in 2022, there's I guess a move away from this movement, where people are reincorporating things like crunches and sit-ups into exercise programs. I still, as of December 16th, 2022, not quite 2023, I still can't justify for the average general population person, individual, applying those multiple cycles of loaded lumbar flexion. There are definitely some instances where I will use it. Now, most of the time, this will be in people that have a strong aversion to loading through the spine, and we're basically doing that to address the fear avoidance that might be present. Or if someone has a very extension sensitive issue and any sort of loading in a static position isn't really comfortable, and they actually feel more comfortable with a loaded flexion, a crunch, or a sit up. I think for those instances it makes sense, and I would do that to a certain point, and then maybe hopefully progress them to more of an anti-extension type exercise. I think that the majority of healthy individuals can probably get away with doing a fair amount of sit-ups and crunches for a relatively long time and not have any ill effects. But I think that there does come a point where we have to consider the orthopedic cost of the movement that we're doing. So this is a really fine and almost contradictory sort of argument that I'm having with myself of about 2 hours ago, that we know that structure isn't directly related to pain, but as our structure starts to change in a way that we would perceive as being less able to tolerate force, less able to tolerate load, then I think that we do start to slowly increase the likelihood of injury. So for me, it makes more sense to train the abdominals in a way to resist movement and focus our force-producing movement at these adjacent segments, such as our hips. And making sure that as we're doing that, we're concurrently getting people to move through the lower back in other, non-direct ways. So I think that, we still need to move, we still need to flex and extend through the lower back, and there's a lot of different movement options for that. But when we're talking about direct spinal loading and direct abdominal stimulus, for me, working on creating a strong isometric contraction where we're getting a lot of muscle activation through our abdominals, but we're not loading the spine in the same way. For me, right now, that is an approach that I am most comfortable with. And when we look at daily function, yes, there's a lot of instances where we are having to move through the lower back, but the times when we're having to produce force, which involve a large amount of abdominal muscle contraction, those tend not to be at times where we have to also require a large amount of lower back movement. So, day-to-day function, we want to think about the abdominals as being an area, or the lower back as being an area of sort of force transfer, where we want to develop the appropriate degree of rigidity and stiffness for that specific task. And if we're training our abdominals, to generate a lot of force, then sort of it makes sense to me for that to be in a position of stiffness rather than training them through range. But I do find this a very interesting topic and debate, and I'm more than willing to discuss it with anyone who wishes to discuss this with me. And I certainly don't condemn the use of loaded lumbar spine flexion exercises. But for me and for my client and patient demographic, it's generally something that I don't incorporate in training programs on a regular basis.
Now, in terms of spinal position with compound exercises, so we're talking about the degree of movement that occurs when you perform something like a squat or a deadlift, where essentially we're looking at it as a compound exercise in that we're using our knee and our hip joint. I think that's what most people think about when they think about a compound lower body exercise, something which involves knee movement and hip movement. In the upper body, it might be something that involves shoulder movement and elbow movement, like a bench press in comparison to like a biceps curl, where you're predominantly using you're isolating muscle contraction around one individual joint. Now, when we look at a movement like a squat or a deadlift, it's a compound movement in terms of using the hips and knees, but you are using a large degree of abdominal and back muscle contraction to control the movement at the lower back, and to also handle the compressive force that goes through the back. And particularly if you're lifting large weights, if you're loading the spine axially, then there's an element of compression which the abdominals must buffer to a certain degree. Now, when we look at someone performing a movement, let's a squat or a deadlift, there will be a certain degree of movement in the lower back, and often you see more flexion at the bottom of a squat, and then maybe at the top there might be a degree of extension. Now, the way that we're traditionally taught to coach these exercises is that the most of the movement should come from the hips and knees, and there should be minimal movement occurring at the lower back. And that's this concept of a neutral spine. Now, I think in recent years we're thinking about neutral spine more in terms of relative neutrality. I think that we understand that it's impossible to keep a neutral spine. And in the studies that we've seen, even when we have a coach, a well-trained coach, look at someone perform an exercise and try to describe the amount of lumbar spine movement occurring, or the lack of lumbar spine movement occurring, there's actually a lot more movement occurring than we think. And given the research that we have on lifting technique and incidence of back pain, there is a movement to sort of be less concerned about the position of the lower back during compound lower limb exercises. Now, for me, and this is just my personal perspective, and I think it's based on a lot of things. It's based on the way that I was taught and that I'm comfortable performing those movements. I think it comes from my martial arts background and my quest to have things performed with what I understand or I perceive as a degree of technical excellence. And so for me, I was always taught and drilled to limit the movement occurring at the lumbar spine and optimize the movement occurring at the legs. And I still feel that even though if we look at the biomechanics and really analyze what's happening at someone's spine when we look at them performing a squat or a deadlift, and that is it's not what we see, I think that there is still some degree of correlation. I think we can look at someone and still have a relative idea of whether they are going into more of a mid-range or end-range amount of lower back movement. So the way that I coach exercises, I still want a squat or a deadlift to be predominantly a hip and knee movement. I think that they are great exercises for developing hip and and knee control. And I think that the benefits that you're getting for the lumbar spine when you're doing those compound movements come through the ability to contract the muscles around the area isometrically. So you're having that stabilizing effect where they're working to limit movement and allow the hips and knees and ankles to a certain degree to produce force. And I think that those are qualities that that people in general, so general population, people need to develop, that athletes need to develop for their sports. When we're sprinting, when we're kicking, when we're jumping, that force is predominantly coming from the legs. You're not jumping using your lower back. So if we're looking at using exercise like a squat and deadlift to optimize force production for athletic tasks and for daily movement, for me, it makes sense to try and limit the movement at the lower back within a certain degree of strictness. And I'm probably fading slightly on that in recent years, but still wanting to see that good what I perceive as good technical execution, where the majority of the movement's coming from the hips and knees. Now, I'm not a powerlifting coach, and so the degree to which someone moves their spine and what is optimal for that individual to lift the maximal amount of weight whilst still being in a position where they're limiting the incidence or the risk of injury long term, because with any sort of sporting task, there's always a risk of injury. We're always going to get injured if we're trying to push the boundaries of athletic performance. We have to decide at a certain degree, what risk of injury is acceptable for a certain degree of success. And that is a difficult question to answer. I think it's it will differ between different people. And I think that we'd still need a lot of research to be able to apply a concept to a large degree of powerlifting or even Olympic lifting athletes based on individual anthropometrics and injury history, how much we can allow the spine to move, how much that enhances performance, and how that sort of fits into injury risk. But like I said, I'm not a powerlifting coach, and I think it is a very complex conversation. But like I said, for the average resistance training enthusiast who wants to develop muscularity in the hips and the legs, obviously you want to develop a certain degree of muscularity in the lower back. But like I said, having the isometric contraction stabilizing for those tasks is going to achieve that. If we're trying to develop force output for athletic tasks, I think the focus should be on trying to maximize the contribution of the legs to that movement.
So the last thing I want to touch on is, what happens when lower back pain doesn't improve? What happens if someone continues to experience symptoms despite the treatments that have been through? And this happens. Unfortunately, we can't resolve everyone's pain. We like to think that through the interventions that we have, we can make a significant change to people's pain. Often we get to a point where we're taking someone's day-to-day pain from a 5 or 6 out of 10 to a 1 or a 2, and through education we make that person understand that 1 or 2 out of 10 pain is not associated with damage. It's just it's just some soreness. That person is sore but safe. And at that point, they're happy living their lives, and a little bit of education about if they do have a slight flare up, it's nothing to be concerned about. It's just a slight aggravation, slight upregulation of the nervous system, and providing people with tools to be able to deal with that when it happens. If someone is continuing with a higher degree of pain, then it does make sense to focus a little bit more on improving quality of life through other means and trying to reduce the suffering that might be associated with that pain. So when we talk about sort of pain and suffering going together, but it is possible to make a change to someone's suffering without necessarily reducing their pain. The evidence we have points towards, again, lifestyle factors. So if someone has a healthier lifestyle, doesn't smoke, limits the alcohol consumption, has good sleep habits, is able to control their psychological stress, gets regular exercise, and has good social support, even if their pain is still present, the impact of that pain is thought to be a lot lower. And so that's one of the things that we sort of focus on with people that are managing chronic pain, is that increasing your health status in other parts of your life is likely to give you tools to be able to manage your life and still live a fulfilled life while still experiencing pain. And the social support part is really important, and often linking people up with other people that are suffering chronic pain can be really rewarding and really beneficial for those people. Hearing stories of other people that are going through what they're going through can take away that sense of loneliness that often accompanies someone who's experiencing chronic pain. Now, other treatment options, we've talked about sort of manual therapy and things like that, and the role of manual therapy. Injections. Look, there are some injection procedures if a lumbar disc herniation is causing some neurological deficits, and we believe that's the main cause of the problem. Then we have an injection called a HerniCore injection. I have talked about this on a previous show, that can basically decrease the amount of disc herniation, basically dissolving that. And then freeing up some of the pressure around the nerve, and that may be an intervention that is warranted. We can inject steroid into the lumbar spine, and again, this is usually in the case where we have direct compression on a nerve that is thought to be caused by inflammation associated with a lower back injury, and the cortisone, being a powerful anti-inflammatory, can decrease some of the pressure around the nerve. I guess the final escalation in management is often surgery, and we know that there's still an excessive number of lower back surgeries being performed all over the world. Like I said earlier, when we have signs of neurological compromise, when we have signs of a compressed nerve, surgery may well be warranted to try and offload the pressure on that nerve. For the average case of lower back pain, it's generally not something that we recommend. And unfortunately, unless there's neurological signs present, the outcomes from lower back pain, from lower back surgery, are not great. However, if someone has tried all other options, then, and they want to go down that route, sometimes it is effective. And whether that's a mechanical thing or whether that's a placebo thing, that, they're investing a certain degree of risk and discomfort associated with the surgery, that alone may be powerful enough to cause a positive response. And, and you can call that a placebo effect, although this is a whole other argument that I don't think have time at this stage in the podcast to go into. But we don't tend to like the word placebo in terms of musculoskeletal treatment, because placebo is really an appropriate term when we talk about pharmacological interventions for health. You can have a pill that has a substance that is biomechanically designed to elicit a specific change to that person's biology, or you can give that person an inert substance which will not have that biological effect. And so if it has a positive effect, it's assumed to be placebo. However, when we're talking about the rehabilitation strategies that I incorporate as a physiotherapist, there's a large cognitive component, and as we've discussed before, there's a large expectancy component to the outcomes that a person experiences. And so to call something a placebo is not really an accurate it basically is referring to a dichotomy that doesn't exist in physiotherapy or rehabilitation. However, if we're going back to the example of the surgery, oftentimes we have a number of examples of surgeries now where people have had similar responses from an actual surgery where the surgical intervention was aimed at a specific biological structure, having no different outcomes to a sham surgery where they opened up the individual and basically sewed them back up again. But that's still, if it improves the symptoms, it's still a valid intervention. And if people go down, if they have tried all other options and they go down that route, we're obviously there to support them with the rehab and the recovery post surgery. So there we go. I've done this in a couple of different sittings today. I'm not sure how long it's going to end up going on for, and I'm not sure how many people are actually still watching or listening. If it's no one, I think that it's still been a fun experience for me to get my thoughts on lower back pain out in a recording. But I do hope that people have taken something away from this. As always, if you are experiencing back pain, please don't hesitate to reach out to us and come and see us and see if we are able to help. At the end, I sort of painted a picture that not everyone gets better, and we have to at some stage, for some people, work on managing life with persistent lower back pain. But for the overarching majority of people that we see, we are able to help and make positive changes to their life. So this is due to be released on the 23rd of December. So if you celebrate Christmas where you are, please have a very Merry Christmas and enjoy this time with those that are close to you. If you don't celebrate Christmas, happy holidays, and I hope that you're able to enjoy some downtime and reflection on the year. And again, time spent with family and friends and those that are close to you. Thanks again for listening to and watching these episodes during 2022. And I look forward to bringing you content and engaging with people next year as well. So thanks for watching. Thanks for listening, and have a Merry Christmas and a Happy New Year, and a safe and prosperous start to 2023.